of the vaccine where we are now. On that topic, what's the current evidence and subsequent role of booster vaccines? This is the buzzword in a lot of community pharmacy settings, with pharmacists being tapped to potentially offer booster vaccines. Who would benefit from a booster, and what is the evidence behind it? And finally, we'll finish off with our younger cohort population, children less than 12 who are unable at this time of the presentation to be vaccinated with the currently approved COVID-19 vaccines. What is the situation going to look like in the fall for that cohort, as well as for pharmacists having to do influenza vaccinations, COVID vaccinations, and routine immunizations as well? So I will pass it on to Angel to do an update from the Public Health Agency of Canada. Oh, I think you're on mute.
Oh, whoops, sorry, there we go. So the way that Ajit and I decided to do this presentation is a little bit more of a didactic back and forth. So we've picked questions and topics that are more relevant as the pandemic has worn on. And just, again, to help our pharmacists, because really you are the frontline people who are going to be faced with a lot of these questions as you're immunizing populations of the general public. And so we wanted really for you to have the knowledge and the tools and the information to best be able to address some of these questions. So there will be a lot of back and forth with Ajit and I, where I'll kind of discuss more of the medical and the clinical side, and then Ajit will kind of give more practical tools for the front line and how you can address some of these questions better. So looking, it seems like it's been forever since the pandemic has started, but, we're pretty much in a year and a half into it. And the Public Health Agency of Canada continues to do weekly epidemiology updates about the state of COVID in Canada. And as you can see that, with the arrival of these COVID vaccines, it's really changed the landscape of who we're seeing COVID cases in and who are being hospitalized and who are dying from the infections and disease. So early on in the pandemic, before the arrival of COVID vaccines, it was the vulnerable populations that were dying and that were being hospitalized. And that predominantly consisted of adults, older adults, living in long-term care facilities, as well as those who had multiple comorbidities. But with the arrival of the vaccines and how successful they've been, it's really changed the landscape, so much so that now we're still seeing COVID infections as well as hospitalizations and deaths, but most of the COVID cases and serious outcomes occur in the unvaccinated population, as well as those who are partially immunized. So partially vaccinated means that individuals may have received only one dose, or they may have been infected in the time before they developed full immunity to the primary series of the vaccine. And you can see that the vaccines have been successful not only in clinical trials where, vaccine efficacies for all of the vaccines, and particularly the mRNA vaccines, were reported to be in the 90+% range, but we're also seeing real world efficacy data where amongst the fully vaccinated populations, we're seeing a very, very small percentage, less than 2% of the fully vaccinated individuals, where we're seeing cases of COVID, hospitalizations, as well as deaths. And really, the majority of the cases and serious outcomes are now occurring in the unvaccinated population. So the first question is, well, what have we learned so far about SARS-CoV-2 infection in humans? Well, once we ask that question, it really opens up a whole can of worms, Pandora's box, and it really opens the floodgates. We have come so far, and even though it seems like it's been a long time since the pandemic started, really the information that the medical community has learned about COVID has been astronomical, and the research and the data at which we're accruing information has just really, really been accelerated. So not only have we learned a lot of lessons on a societal level, but also on a community level, as well as on personal and interpersonal levels as well. But really, we thought we'd focus the attention more on some topical issues, including the multi-inflammatory system diseases that we're seeing in children and adults, myocarditis, as well as long COVID syndromes. So I know a lot of the community and patients are coming in worried about this phenomenon known as multisystem inflammatory syndrome in children, otherwise known as MIS-C. And when you look in the literature, there's many different terminology for this syndrome. And the name of the syndrome has evolved as the pandemic has come along. But early on in the pandemic, we knew, even though we were worried about children, because children are usually susceptible to these types of respiratory infections, what was interesting about COVID is that children weren't really being affected by COVID, not only in case numbers, but also in severity of outcomes. And it was really older adults that were succumbing to severe COVID disease. But what was interesting is that there were these reports of children who had had COVID, either mild infections or even in some cases asymptomatic infections, who were developing fever of unknown origin that persisted. And then in some cases, very rarely, some of these children progressed rapidly into multisystem organ failure. And so this multisystem inflammatory syndrome in children has now been termed MIS-C, where it's this syndrome of this post-viral hyperinflammatory condition affecting multiple organ systems. And the pattern is that it's usually seen about 2 to 6 weeks after the peak of COVID-19 infection outbreaks in the community. So if there is an outbreak in a local jurisdiction, then we tend to see MIS-C occurring in children about 2 to 6 weeks later. And with this type of a syndrome, it's really idiosyncratic. And there's many definitions according to, depending on where you're looking. So Europe has a different definition or different case definition. Canada doesn't really have clinical criteria for the definition. But according to the CDC, the way that CDC defines a case is if anyone who is less than 21 years of age presents with a fever, and that's the most common presentation, along with laboratory evidence of inflammation, and that includes things like an elevated ESR or a CRP or a ferritin or liver enzyme abnormalities. And if they have evidence of clinically severe illness requiring hospitalization with over 2 organ involvement, and any organ can be involved, including cardiac, renal, respiratory, hematologic, gastrointestinal, dermatological, or neurologic conditions. So it's a vast array of symptoms, and no alternative plausible diagnosis. And that individual had to have had a positive SARS-CoV-2 infection, either by PCR, serology, or antigen test, or at least exposure to a suspected or confirmed case of COVID-19 within the last 4 weeks prior to the onset of symptoms. So in most of these cases, it's a post-infectious hyperinflammatory condition where it's not an acute infection that causes this syndrome. It's something that happens afterwards, where it's just this immune dysregulation that kicks the immune system into overdrive. And it's very similar to Kawasaki's disease, which we typically see in children, where there's an infectious trigger, usually a viral etiology, and it sets off the immune system. And most commonly, these children present with a persistent fever. A lot of the times they have gastrointestinal pain, so just tummy upset. They might have some diarrhea, along with a conjunctivitis or a skin rash. And those are usually the most common presentations. Thankfully, though, the literature suggests that children who develop this multisystem inflammatory syndrome, if diagnosed early and recognized, so there has to be a high index of suspicion, these children tend to do very well afterwards with no types of prolonged objective abnormalities that persist. Now, along with that, when MIS-C was first recognized in children, the literature has now recognized that a very similar syndrome can occur in adults. And that term has now been termed MIS-A for adults. And the definition for adults is any individual over the age of 21 who's been hospitalized for over 24 hours or with an illness resulting in death without a more likely alternative diagnosis with at least 3 of either the primary clinical criteria or secondary clinical criteria. And the primary clinical criteria, according to the CDC, can include severe cardiac illness. And again, it's a vast array ranging from myocarditis, pericarditis, all the way to AV blocks, arrhythmias, as well as new onset ventricular dysfunction. Sometimes adults may present with a rash and a conjunctivitis as well. And then secondary clinical criteria can include new neurologic signs or symptoms. Again, a vast array of symptoms, including encephalopathy, seizures, meningeal signs, along with shock or hypotension, abdominal pain, vomiting, diarrhea, or thrombocytopenia. They also must have laboratory evidence of inflammation, similar to what we see in children, and SARS-CoV-2 infection. Now with MIS-A, the literature doesn't have as many reports as with MIS-C as what we're seeing in children. So this syndrome is still relatively new in the literature. Again, very, very idiosyncratic. In Canada, the PHAC has reviewed and done a case literature of all the cases reported of MIS-A. And as of August 2021, they've reported 9 cases reported worldwide. So very, very rare. And of these 9 cases, all individuals were hospitalized with multisystem organ failure, but the vast majority did very, very well. And it only resulted, and of these 9 cases, there was only 1 death in a woman who was multi-comorbid. And also had a variety of other things going on. The clinical features is that there is no rhyme or reason to it. The occurrence tended to be in the post-acute phase, so very similar to what we're seeing in children. It's not a result of the COVID infection itself, but again, it's this dysregulation of the immune system, which causes this hyperinflammatory syndrome, a macrophage activating syndrome, or a cytokine storm release type of a presentation. The most common clinical features that these cases had in common were fever, digestive symptoms, so GI upset, and then a lot of these cases had cardiac involvement along with elevated inflammatory markers. And beyond that, there really was no pattern to either of these syndromes. Now, moving along, there now has been this syndrome of long COVID or persistent COVID symptoms, and it's increasingly recognized and along the spectrum of a chronic fatigue syndrome, which we typically tend to see with a lot of other viral respiratory illnesses as well. So long COVID is really a post-COVID syndrome where somebody has persistent or delayed symptoms that last or appear more than 3 weeks since illness onset. So if somebody has symptoms related to COVID that persist beyond 3 weeks, then we term them to be long COVID. Now, with this long COVID syndrome, it can actually occur in anyone who has had COVID, even in those who've had mild illness or were initially asymptomatic. So it doesn't necessarily correlate with severity of their COVID symptoms, because even asymptomatic individuals can tend to develop long COVID symptoms. Now, what are these long COVID symptoms? Well, they're very, very extensive. So it can be anywhere from persistent respiratory symptoms like shortness of breath. Fatigue is a common one where it's recognized, and we're doing a lot of European data is showing that individuals who've had COVID tend to describe more of a chronic fatigue syndrome that lasts beyond 24 weeks after their symptom onset or after their COVID diagnosis. A lot of times patients complain that their symptoms get worse after physical or mental activities. They oftentimes refer to this brain fog. They may have persistent cough, chest pain, shortness of breath, headache, pounding heart, muscle aches, diarrhea, sleep problems, especially insomnia. They might have lightheadedness as well, rash, mood changes, changes in smell or taste. And for women, they may have changes in their menstrual cycle as well. And the ones that I've starred are because this long COVID syndrome can be recognized in children as well. And so the ones that I've starred, including fatigue, cough, and headache, are the most common symptoms that are reported in children, along with sleep problems. So this is a recognized syndrome. It is real, and there are some clinics that have now been opened up that require multidisciplinary attention to deal with these long COVID symptoms, including the use of physiotherapists, occupational therapists, respirologists, rheumatologists, neurologists, et cetera, that help to manage all these multisystem persisting symptoms as well. So the data and the science is evolving in regards to this syndrome. So what about myocarditis after mRNA vaccines? Because it wasn't a thing that was seen in the clinical trials with either of the Pfizer or Moderna mRNA vaccines. But in the real world, when we were using millions and millions of these doses, we were finding that there were associations of increased rates of myocarditis in recipients who've received mRNA vaccines. Well, now that we've had much more clinical and real world experience with mRNA vaccines, there was actually a publication that just came out a couple of weeks ago in the New England Journal of Medicine, which looked at the rate of myocarditis after mRNA vaccines and compared it to the risk of myocarditis after COVID, because we know that if somebody has a natural infection to COVID, they can oftentimes develop a myocarditis and pericarditis as well. So what is the risk with mRNA vaccines versus a natural infection with COVID, along with other symptoms as well? So what this study found was that when they looked at the absolute excess risk of various adverse events after vaccination versus the SARS-CoV-2 infection, you can see that the risk of developing myocarditis is actually much higher in persons who've had a natural SARS-CoV-2 infection compared to those who've received the mRNA vaccine. So when you have a patient coming into your pharmacy clinics, worried about getting myocarditis after mRNA vaccines, we can actually assure them that, well, your risk of getting myocarditis with a natural infection is actually much higher than if you've had an mRNA vaccine. So it's actually even more reason to get vaccinated, because if you want to protect yourself and you want to protect your heart, well, then you don't want to get COVID, because the risk of damaging your heart with COVID is much higher than with mRNA vaccines. And it's the same thing with pericarditis. And in fact, when you look at all of these other adverse events, including acute kidney injury, arrhythmias, DVTs, PEs, the risk of actually developing any of these adverse events is actually much higher with the natural SARS-CoV-2 infection compared to getting mRNA vaccines. So again, even more reason and a more compelling reason for individuals to get vaccinated with mRNA vaccines, because if they want to protect their heart and they want to protect their kidneys, and they want to protect against blood clots, well, then the best way is to get vaccinated, because if they get COVID, then their risk of developing any of these cardiac or renal adverse events is actually much higher if they get COVID compared to being vaccinated. But that, I'll hand that over to Ajit.
Yeah, so that's an excellent point, Sarah Angel, and I really like how you ended there with looking at the relative risk of a lot of these adverse events that in the pharmacy we see a lot of patients, especially as we get later into this vaccine campaign, expressing concern of both short-term and long-term side effects. And it really puts it into perspective of what the risks of these things from COVID are versus the actual vaccination itself. And that brings me to how do we leverage this to address vaccine hesitancy? So I think most of you are familiar with the three domains of vaccine hesitancy, being confidence, complacency, or convenience, the three C's as we call it. And as pharmacists, we really do a great job addressing the convenience of all vaccinations by being able to administer that into in our practice. But for COVID-19, the complacency is really a big one that we need to leverage with these discussions, especially as we get later on and try and push and grind our way to getting to herd immunity across the country. And that's the perception that vaccine preventable disease risks are low, and the vaccines are not a necessary preventative measure. So I'll go to the next slide, please. And Angel talked about long COVID and being from the province of British Columbia. She's absolutely correct. Even here, there are massive interdisciplinary clinics that are expanding. It does take a multidisciplinary approach because the ramifications of this disease has lasting implications that require different treatment modalities. So when we look at sort of individuals who say, for example, I'm concerned because the vaccine was too fast. It was made available too fast. The first thing I always say, well, with something that the whole world was working on and all the brilliant minds are working on, it still took a long time. And if you talk to those families who lost loved ones for COVID-19, I'm sure they don't share the same sentiment, especially when we look at the glaring statistics of hospitalization data with how poorly the unvaccinated are doing with COVID-19. And as Angel mentioned, the distribution of the elderly and the vulnerable shifting to younger, more healthy people who simply are there because they're unvaccinated and they've made the wrong choice. When we look at things like long COVID, we're still wrapping our head around what exactly this disease does to people. And Angel mentioned the word immune system dysregulation when we look at these multisystem inflammatory syndromes. And a lot of patients coming in are saying, well, isn't it just better to get the natural infection and the natural immunity? Well, the natural immunity does not last very long. It's potentially protective for 3 months, but after that, it's pretty much wanes quite quickly. And when it comes to long-term side effects of vaccinations, we have very good understanding on what a controlled immune response can do and what it can't do. But when it comes to COVID-19, we're still evolving our learning. So we'll go to the next slide. So in terms of those patients in your practice who wonder, is 6 weeks post-vaccination enough of a limit to do post-surveillance, and is 2 months in the clinical trials? Because when you're starting to see patients now, they are starting to read, and a little bit of information is quite dangerous. So when they say, well, from a safety perspective, it is mostly 2-month follow-up, but in reality, when we look at 100 years of vaccine development, adverse events plausibly linked to vaccine administration, typically the outer limit of when they appear is 6 weeks from vaccine receipt. And when you saw those slides on long COVID, you're looking at potentially lifelong complications of disease. So we'll go to the next slide. So when you're administering vaccinations in your practice, there's a couple things we can look at in order to, again, ease your patient's concerns while at the same time providing immunization safely. So when we look at the adverse event timeline, the first thing that happens is the vaccine is given. And before we start going across the timeline, I'm going to jump to 48 hours here, where perhaps the most common vaccine-related side effect that's actually reported is misadministration. So going too high and potentially injecting into the shoulder joint capsule, into the bursa, causing something called shoulder injury related to vaccine administration. And that typically occurs within 48 hours, and it can be a lengthy recovery process if the vaccine is administered in that area. So again, many of you have been doing immunizations for a long time. You're familiar with landmarking, but each arm is potentially different. We're seeing skinny arms, muscular arms, potentially stroke arms, different anatomies. So again, just being careful to landmark each time you administer. And even I find myself getting into that sort of pattern where, I know a deltoid. When I see one, I can eyeball it. I still landmark. I even cup the deltoid each time because I know the statistics are, this is the most common injury from a vaccine. It's not those weird side effects your patients are talking about. It's potentially something you can control. So I think that's something that's really important because we're having to administer a lot of vaccines in the pharmacy these days. Within 1 hour, and again, some of you have seen this as well, especially in your youth patients. So extreme emotional distress and triggers, because needle phobia and things like this can elicit it. It can lead to some fainting. So again, carefully screen your patients, because the last thing you want is to administer a vaccine to someone and then they fall and sustain a head injury. And again, that leads to a bad outcome from vaccination that can be prevented. So do remember to keep screening for potential emotional distress, as well as history of fainting. And even if someone is kind of looking a little pale, they're nervous, having them lie down is an excellent way to immunize safely, because if they do have a vasovagal, they're lying down, so there's not going to be an issue. Typically, anaphylaxis, we monitor for 15 minutes, and that's sort of the time limit where it could appear. Many of you who are administering vaccinations, do monitor your aftercare for this phenomenon, but do let your patients know that the onset could be delayed, so they do experience any swelling, shortness of breath, to seek medical attention immediately. And then as we go to the outer limit, this is where things get a little interesting. So encephalopathy actually probably shouldn't even list this because it's from vaccines containing whole cell pertussis bacteria. So now we administer the acellular pertussis vaccine. So not really an issue at this juncture with the vaccines you're administering. And then when we get to the 6-week mark, we start to look at some of these quote unquote vaccine injuries and these sort of autoimmune mediated responses that a lot of people are concerned about. Well, my immune system, my cousin got rheumatoid arthritis from a flu shot. And in reality, diseases, as Angel mentioned, are the real culprit for triggering autoimmune diseases. You basically have something that's completely untested, unproven, unpredictable, that is making copies very rapidly in your body, and your body's doing whatever it can to stop it. So versus something that's tested, strategically delivering a message that's recruiting specific cells to elicit a specific response is completely different than letting a wild type virus run rampant. So when we look at things like intussusception, we see that with rotavirus. We also have to be mindful of baseline risk of disease. In that demographic of children who get the rotavirus vaccine, there is an increased baseline risk of intussusception. Even with myocarditis, and I always structure my counseling on myocarditis, I do mention it, but I always give it some sort of perspective, because the key thing is you want to give people the absolute full picture of what their risk is. So first of all, there is a baseline risk of myocarditis. People get myocarditis who are unvaccinated. People get myocarditis before COVID, and people will continue to get myocarditis after COVID. And then putting the perspective of if you do get COVID, then the risk of this is a lot higher. So when we look at something like Guillain-Barré syndrome, many of you, when you give your flu shot, say, well, there's a 1 in a million chance of getting Guillain-Barré syndrome. But there's actually a 17 in a million chance of getting Guillain-Barré syndrome from influenza. So in reality, that vaccination that you're saying there's a rare event to is actually protective of that very side effect that you're counseling against. So be sure to give that sort of perspective to your patients, because they often trust you and your opinion when you discuss these vaccines. And I certainly find it certainly calms their anxiety when they've had these misconceptions about vaccination. So we'll go to the next slide. So this is from the, again, giving some perspective. So a lot of sort of anti-vax sentiments out of the United States mention this sort of vaccine injury fund. It's something that was put together in the United States to avoid excessive litigation against vaccine manufacturers. So if this sort of causal event, because again, as Angel mentioned, when you vaccinate in a clinical trial with 40,000 people, as soon as you're rolling into hundreds of million, you're going to pick up potentially undetected safety signals. So this was a means to kind of say, okay, well, vaccines are important. We need people to develop them. But at the same time, we want to protect patients. If they are potentially injured by a vaccine, they can be compensated. So a lot of these claims are very causal in nature, very coincidental in nature, with no causality. And what they found is that for every 1 million doses, potentially one individual was compensated. And again, most of those came from the severe shoulder-related administration of vaccination, something that can be controlled. We'll go to the next slide. So as we continue, again, this is just to illustrate, this is a series called ECHO. For those of you in BC, I'm sure there's other sort of learning sessions for clinicians about post-recovery COVID-19, but it just shows. So ECHO is something out of BC. It's free monthly 1-hour webinar sessions. And again, it just shows how much more we're learning about post-COVID and long COVID, that there's new educational content coming out every month. When it comes to vaccinations, and I'm sure Angel can attest to this, the incidence of these signals and events that we're seeing are very predictable, as we see with vaccine development and administration. And that doesn't stop with COVID-19. And it's important to leverage the burden of other vaccine preventable diseases to address whatever hesitancy your patients have. I talked about influenza, even pneumococcal disease, some of the burdens, all of these sort of respiratory infections consume the same resources. And we look at something like blood clots, any medical sort of infection that you're bedridden increases the risk of blood clots because you're stagnant. So again, it's not limited to COVID-19. There's inflammatory responses from these other diseases. Even with shingles, a lot of people say it's a painful rash. But at the same time, there's complications like postherpetic neuralgia, which can last a lifetime of visits with chronic pain specialists using medications like gabapentin, which have side effects, and then you're taking more medications for those side effects, all of which could be prevented and mitigated by getting vaccinated. And we'll go to the next slide, please.
Perfect.
So
All right.
pass it on to Angel to answer question 2, the big question about variants.
So thank you very much, Ajit, for that. Yeah, it's, and I think especially, I love that last point that you just highlighted, just the impact on other vaccine preventable diseases and how now there's so much attention and knowledge and awareness about the importance of vaccines that we really need to leverage this opportunity to make sure that all of our patients are optimized with the other vaccines that may have been neglected in the past. So the second question that's topical is, what impacts have the emergence of these new variants had on the pandemic, and what impact does that have on vaccine effectiveness? So it's important to know that even though variants, the media has really hyped it up and made it seem like it's a scary thing, keep in mind that variants, all it means is that there's been a genetic mutation in the sequence, in the base pair genomic sequence of the virus. And viruses as a group, as a family, as a entity, if you will, continue to mutate. This is what bacteria and viruses do. This is the microbiological world where viruses will constantly be restored. They'll have changed just a single base pair in, 10 million base pair sequence, and one mutation, one change in a base pair is enough to call it a mutant or a variant. So this is normal. This happens naturally all the time. It doesn't necessarily mean it's a scary or alarming thing, like the media has portrayed it. And it's important not to be too alarmed and to be too reactionary to it, but just to take a step back and reassure our patients that yes, there are these variants and mutations that have happened, but it doesn't necessarily make the virus any more virulent or different or dangerous in any way. What changes and what needs to be monitored about these variants is that even though viruses continually mutate, it's the variants of concern that have the potential for increased transmissibility. And that's where this whole concern about Delta is, because we certainly are seeing epidemiologically that this Delta variant is more highly transmissible. But it's debatable whether or not it actually causes more severe disease. There's the potential for it. But so far, the data with the Delta variant, at least from the UK, is that even though there's increased transmissibility, we're not actually seeing more severe disease with it. And of course, that may vary depending on the country that reports it. But then with these variants of concern, there's also the potential for reduced effectiveness of treatments or vaccines. And also it may escape our diagnostic detection failures. So there are a lot of things with these variants of concern that need to be monitored for, but certainly nothing, that needs to sound the alarm bells just as of yet. Now, what impact do these variants have on vaccine effectiveness? Well, Ajit alluded to this, where the vaccines were developed early on in the pandemic with the wild type virus before these mutants or variants were recognized. But now that these variants have emerged and we have real world studies where we're using these vaccines in the real world studies have still demonstrated that the COVID vaccines are still highly effective against confirmed and symptomatic infections from the Delta variant, albeit at lower rates. So instead of the 90+ vaccine efficacies that were reported with mRNA vaccines, we're finding that mRNA vaccines are reported to be anywhere between 72 to 88% efficacious against the Delta variant in the real world. But what the real world has also shown is that even though there's been a reduced vaccine effectiveness against hospitalizations was still very high in anywhere between 93 to 100% range. So even though we're seeing reduced vaccine effectiveness against confirmed or symptomatic infections, vaccine effectiveness against serious outcomes like hospitalizations is still quite high. And so that's why right now there's been no no recommendation for changing any of the COVID vaccines, because we're still finding that in the real world, the original COVID vaccines still have very high effectiveness, and they're still very, very protective. So right now, all of the governments and health agencies are monitoring these variants of concerns with no current recommendations for targeted vaccines. So I'll pass it off to Wajid.
Excellent. Some great points there to further illustrate why more people need to get vaccinated with the excellent vaccines that we have available. So as Angel mentioned, that the vaccine effectiveness is shown to be a bit lower with the variant. But we also need to kind of put some perspective on mainly when patients come to us and say, well, I saw on the news that the effectiveness drops to this or this drops to that. And the thing is, I turn to them and say, well, effectiveness against what? What does that mean? So a lot of times when we look at, potential losses of effectiveness, we look at antibodies, which are a correlate of protection and not indicative of the great data we have on things like hospitalizations and death. But to offer some insight on why fully vaccinated people are still getting infected with COVID-19, you notice the word infected. So again, that's different than actually having disease, where individuals who are vaccinated could potentially be asymptomatic and could potentially even transmit the virus. And here's some insight on that. So we'll go to the next slide here. So when we actually look at answering this question, we always start with what was the vaccine designed to do in the clinical trials? And this is from the Pfizer-BioNTech vaccination trial. I chose to show this slide because that's what most Canadians are vaccinated against. But when we look at all the vaccines that are approved, they develop their trials in a similar fashion. So the only time prior infection status, a swab for SARS-CoV-2 PCR was done was in the 21 days between the vaccination period. As soon as people were fully vaccinated in the trial, the follow-up period was consistent with active surveillance. So symptoms of disease. So the vaccines were not designed to prevent against infection, they were designed to prevent against disease. So the only time that individuals in the trial triggered an event in the active surveillance is when they exhibited symptoms of the disease. So we'll go to the next slide here. So when we look at this excellent data, it's the cumulative incidence of COVID-19 after the first dose and then the second dose of the Pfizer vaccine. And you can see those lines diverge quite a bit because it's measuring in the top line, the incidence started to go up in the unvaccinated cohort. And we're seeing that with that excellent p-HAC diagram that Angel showed at the start of the presentation, with the burden of hospitalizations and death being disease in the unvaccinated group, as well as cases themselves. So a lot of times cases as they're identified are triggered by symptoms, right? That's how public health tests are ordered. Anybody with symptoms, we rule out COVID-19. So you can see there's, again, over 85% in all modalities, hospitalizations, death, and cases all being disease in the unvaccinated cohort. So go to the next slide. So that brings us back to, as we're providing vaccinations in our pharmacy practice, and we still need to keep the infection control hierarchy when we're administering vaccines, because even if everyone in our workplace is vaccinated and everybody coming in for, if it's a COVID vaccine, then they're not vaccinated, but if they're coming in for other vaccinations and they're fully vaccinated against COVID, we still want to limit transmission of the virus. So we want to continue with elimination controls, such as screening, engineering controls, such as workflow, one-way exit, allowing for social distancing, sanitization between vaccine appointments, administrative controls, hopefully separating dispensary from vaccination services to avoid crowding, proper ventilation, and then you'll notice again, PPE is at the bottom of that pyramid, but still plays a role to prevent pathogen exposure. And for vaccinations, that would consist of a medical mask, eye protection, and gloves are only needed if you're doing non-intact skin. So it would be eye protection and a medical mask. So to maintain those protections as you start vaccinating more and more against COVID-19, as well as influenza in your pharmacy. So we'll go to the next slide. And now we move to booster shots. Oh, just sorry, Angel, you're on mute there.
Sorry, keep doing that. So yes, this is quite topical because NACI at the end of day Friday afternoon just came out with a recommendation on a booster or an additional dose of COVID vaccines. So what's the rationale for this additional dose? Well, it's twofold. So we know that in those who've developed adequate immunity after the primary vaccine series, we know that vaccine-induced immunity does wane over time. So once somebody has received their primary vaccine series, a few months down the road, their vaccine immunity declines, their antibody levels decline. And so the idea behind a booster dose is that it will restore that antibody level, even though there's no correlative protection, but it'll boost up the antibody level and hopefully restore full protection against COVID infections and serious outcomes. So that's the rationale for a booster dose. And not only that, but we're seeing that even amongst fully vaccinated individuals, there still are individuals who are getting COVID infections. And one of the reasons may be is that those who are fully vaccinated, and as societies and economies have opened back up again, they are returning to pre-pandemic behaviors, which could potentially increase their exposure to high viral loads that are still circulating in the community. And that high viral load may overwhelm the antibody and the immunity that has developed after the primary vaccine series. So that's the rationale for an additional dose. Now, with immunocompromised individuals, we know now that immunocompromised individuals are at increased risk of having prolonged COVID infections, and they're at about 4 to 5 times higher risk of developing severe COVID disease compared to the general population. So immunocompromised individuals are at highest risk. We also know that they do have reduced immune responses to a 2-dose primary mRNA vaccine series, whether it's with the Pfizer-BioNTech or the Moderna vaccines. With the clinical trials with the mRNA vaccines, as with most clinical trials, immunocompromised individuals are usually excluded in phase 3 clinical trials in the first set, and then later on they tend to do separate trials for immunocompromised. But because immunocompromised individuals were excluded from the initial vaccine trials, we don't actually have a lot of data about its efficacy in immunocompromised people. But we knew in the real world, once we started using mRNA vaccines, that they did have reduced immune responses. And in the real world, we're also finding that immunocompromised people have reduced vaccine effectiveness compared to the general population. So it's not as highly effective. But we also know that if we give a third dose to immunocompromised people, that we can boost their antibody responses to a level that's seen in somebody who's not immunocompromised with a similar reactogenicity profile. So the risk benefit is actually quite high because you're giving them a third dose, you boost their antibody responses, and yet they're not developing any kind of increased adverse events. So there's a lot of rationale for using a third dose in immunocompromised people. And a real world study in Israel, it's preprint, it's not been peer reviewed yet, but it's suggesting that because in Israel, they've actually started administering a third dose to adults 60 plus. And what they're finding is that by giving that additional third dose, it's suggesting about a 70 to 84% reduction in the risk of infection about 14 to 20 days after that third dose. So there's actually real world evidence that giving a third dose to adults over 60 is actually increases the protection against COVID. So on August the 23rd, the FDA actually approved a third dose of Pfizer vaccine on an emergency use authorization basis, as well as for the Moderna vaccines, at least 28 days after the 2-dose primary series for those who have undergone solid organ transplants or who had an equivalent level of immunocompromise. And then on Friday afternoon, NACI came out with a recommendation after reviewing the limited data about third dose. But NACI, based on a risk-benefit assessment, recommended a 3-dose mRNA primary vaccine series for moderate to severely immunocompromised. So if anybody who's moderately or severely immunocompromised, if they have not received their mRNA vaccines yet, should receive a 3-dose primary series. And those who've already received 1 or 2 doses of a complete primary series, whether it's with the mRNA or the viral vector vaccine, they should receive an additional dose of the mRNA vaccine. And the only reason they suggest an mRNA vaccine is because there's been no data on the benefit of an additional dose of a viral vector vaccine in this population. And NACI recommends that the minimal interval between the 1 or 2 dose primary series and the additional dose should be 28 days. But also keep in mind that the longer we extend out the interval, then the more susceptible that individual will be to getting COVID and all of the potential complications that can arise from it. And as with vaccinating all immunocompromised individuals, NACI recommends to administer all vaccines at a period during which their immunocompromised state is at its lowest level. So, and it varies depending on the medication that an individual is at. If their immunosuppressive medication can be held, that would be ideal. But if not, then you would never delay a dose of a vaccine, waiting for the immunocompromised state to improve. And then it's also important that when we're counseling patients that we should have informed consent about the limited evidence for the use of an additional dose of any of the currently authorized COVID vaccines and the unknown risk of myocarditis or pericarditis after a 3rd dose of mRNA vaccine. With that, I'll hand it over to Ajit.
Yeah, some excellent points on booster vaccinations. And when we really look at the story of booster vaccinations, Angel, you're absolutely correct. With those who are immunocompromised either by medical condition or medications, their responses to all vaccines are lower. So scientifically, this is nothing new that we're seeing, and this recommendation does not come as a surprise. But where we want to kind of look towards in the fall season is we look at immunocompromised, but what about immunosenesced? So we know, like, as we age, our immune system sort of ages with us. So we've noticed that, for example, in Israel, there is breakthrough cases of vaccinated elderly individuals from COVID-19. And here's kind of, again, how we can look to explain why this is happening. So we'll go to the next slide. So again, goes back to anytime you want to solve a conundrum, is go back to the clinical trial and find out exactly what happened and how it was done to get the data that was found. So we zero in now on the age breakdown of the demographic of the clinical trial. And again, I've used the Pfizer-BioNTech trial because in Israel, that's the vaccine that was exclusively used. When we look at the age breakdown, when we look at individuals over the age of 65, they comprise about 20% of the demographic in that trial. So those under 65 was 80%, over 65 was 20%. So again, that's completely different than how we started our vaccination campaigns based on risk. We ran about 90% of those over 65 and probably 10% of those under 65 because the elderly were at higher risk. So these individuals were vaccinated first. They were vaccinated at a time when the variants were in circulation. And again, they were vaccinated early, so we would expect some waning of protection. So we take our most vulnerable individuals, vaccinate them first, and then our younger cohort second, we will potentially see some waning of immunity. So that is a really good way to look at why that's happening if your patients have questions of why people in Israel and they're still vaccinated when they're sick. Going back to what Angel said earlier, when we look at sort of breakthrough cases, they make up a small percentage of the hospitalizations, less than 2%, as she said. And typically it's in elderly individuals. In Israel, they're saying elderly individuals who probably are so frail they would have been there for something else, which is still inexcusable for the 85+% who are young and healthy and should not be there just because they chose not to get vaccinated. We'll go to the next slide. So as Angel mentioned, the Israeli findings did in the preprint that it does significantly boost and lower the infection risk. We'll go to the next slide. And again, this is nothing new from other vaccines. So even when we look at influenza vaccinations, those over 65 still don't do as well as those under with standard dose formulations. You can see vaccine effectiveness for those for those over 65 are much lower than those under 65. We'll go to the next slide. And just a reminder coming into this influenza season is to really look at optimizing the vaccinations in your vulnerable patients. If there are no boosters for those over 65, consider optimizing their protection in another way. Instead of the standard dose influenza vaccination formulation, either an adjuvanted product or the high dose product, which has been shown clinically proven to reduce death and hospitalization from influenza. So again, a dot does not make a line. We're building on the science we already know. In the absence of boosters and data, we still have a lot of good data on other ways to protect our vulnerable patients. Next slide. And we will wrap up here with our last question. Angel will talk about children less than 12 years of age. Oh, sorry, and then the toggle back and forth.
Sorry, I know. So sorry, yes, and of course, this is of concern, especially with our little ones. Schools have just, started back up. We're already starting to hear about outbreaks occur in schools and whatnot. And because there's no vaccinations that are currently available for anyone who's less than the age of 12, we're worried about our children. So rest assured that pediatric COVID vaccine trials are currently being conducted. And I think the youngest age groups that they're looking at are from the ages of 6 months and up. So hopefully in the next few weeks to a few months, we'll get some pediatric data, and perhaps the COVID vaccines would be available for our children who are less than the age of 12. But according to an MMWR report just recently released by the CDC, what they noted in the US is that hospitalization rates amongst unvaccinated 12 to 17-year-olds was about 10 times higher than vaccinated. So similar to what we're seeing in Canada, where the majority of cases and hospitalizations are occurring in the unvaccinated population. And what they found in the US is that the hospitalization rates amongst children were actually about 4 times higher in states with the lowest overall vaccination coverage rates. But despite seeing increased cases and hospitalizations in children, particularly amongst the unvaccinated or lowest vaccinated populations, we're actually not seeing, or at least in the US, there's been no increase in disease severity despite increased cases in children. So that is very reassuring. And so even though we're detecting cases, and kind of what Ajit touched on before, even though we're detecting cases, it's not increased severity. And really, this study just goes to highlight the importance of community level vaccination as the very best way to protect children until direct immunization is possible. So if you want to protect your children, then make sure that the community and all those around you are vaccinated. And let's not forget that even though COVID is still very, very top of mind, let's not forget about routine immunizations and other childhood vaccine preventable diseases, because we know that other vaccine preventable disease immunization rates have declined significantly, especially with the interruptions in school systems and public health immunization programs. And without continuing on with these routine immunizations, these other vaccine preventable diseases, which are in some cases as severe or even if not even more severe than COVID, will come roaring back, and our children will face a whole bunch of new problems if these other vaccine preventable diseases come back into our communities.
Which is a great way we can wrap up the presentation here. So this is nothing new. This is actually data from West Africa. So when we try and fight one infectious disease crisis, we often neglect others, and it does come roaring back. So this is the Ebola epidemic, and this actually has nothing to do with vaccinations for other things. It's about social distancing, lockdowns, and a lack of availability and access to healthcare services. So in these West African regions, during the peak of the Ebola crisis in the region, the resurgence of measles due to the reduction in measles vaccinations because of the Ebola epidemic resurfaced during this time. So we don't want things like that to happen here. And there happened during the lockdown. A lot of school-based programs have stopped. And also just during the COVID-19 vaccination campaign, where it's been all hands on deck for COVID. If we look one way, we still have to look at preventing other diseases as well. So we'll go to the next slide. And as a pharmacist and for fellow pharmacists, coast to coast, just some last tips to provide immunization services in your pharmacy. So again, remembering we want to optimize the visit and we want to co-administer as many vaccines as possible to get protection faster and to minimize the number of healthcare encounters. Next slide. When it comes to co-administration, there's mixed guidance on this, but in reality, we're seeing a sort of a general scientific shift to co-administration. At the end of the day, while there's no formal studies of co-administration, general guidelines in immunization, if you look at all immunizations, is to use every visit as an opportunity to offer recommended vaccines. So the BC CDC has changed their stance, the CDC has changed their stance, and hopefully NACI will change the co-administration guidelines as well, especially as we get into influenza season. Next slide. As we move into influenza season, we can't be complacent. Yes, it was a low burden season compared to the previous year. A lot of things like social distancing. Angel also mentioned, as we get to pre-pandemic interactions and exposures, we can expect this to go up. So we want people to still be protected and not spread disease. Next slide. Finally, as a wrap up of this webinar, from a workflow perspective, many pharmacies across the country and pharmacists have been doing vaccinations year round, starting with last year's flu season and moving with the administration of various COVID vaccines, whether they be viral vector or mRNA vaccines. Some lessons we've seen is that websites, wait lists, and registration work a lot better than calling or lining up in crowded pharmacies. Staffing is important to support your staff and to provide adequate staffing to avoid burnout and to accommodate this change in your practice, which is going to be here for a long time and it's going to stay with immunizations. Booking platforms and inventory management are also all important. And as we're starting to see the importance of immunization records, knowing who's vaccinated and who isn't, hopefully we'll see pharmacists get more access to things like immunization records in order to provide this service more robustly. And with that, we will wrap up. Thank you so much for attending. We'd be happy to take any questions. Back to Phil.
Great. Thank you very much for that, Ajit and Angel. Thank you for sharing your expertise with us. There have been some really good questions that have come up. I suppose the first one, again, the topic of third doses is really so top of mind right now in the media. And along with that is the whole discussion, which is the waning of response to the vaccines. So a lot of the data that's come out has been about homologous schedules of mRNA vaccines or viral vector vaccines, but many Canadians up to this point have received a hybrid schedule of a viral vaccine and an mRNA vaccine. And the question I have is there any data at all, or should we be looking at this particular patient population to respond any differently in terms of the waning of their the vaccine effectiveness?
Yeah, that's a great question, Phil. And, with the science and the way that COVID has evolved so quickly, unfortunately, we've had to rely on a lot of real world experience rather than clinical data. And so there's actually been no real good clinical trial data looking at mixed schedules, like a heterologous schedule, as you suggested, using mixed mRNA and viral vector vaccines. But there is a real world study. They are being conducted currently. But right now, there's really no good formal clinical trial data in regards to a mixed schedule and the efficacy that you can glean from it. For the third dose schedule, NACI has said that if somebody has received a mixed schedule, that third dose should be an mRNA vaccine, because there's just no data with using an additional dose of the viral vector.
Excellent, thanks. And I guess a follow-up question that came up in the chat was that for patients who qualify for a third dose because they're immunocompromised, we talk about a minimum recommended interval between the second and third dose. Is there a maximum interval or a maximum time frame before it becomes sort of like a restart of the original schedule?
Yeah, so again, the data is evolving, and it's important to remember that even though NACI has recommended an additional dose for immunocompromised, the data is very, very early on, and it's not, you know, I guess it's still early and based on really expert opinion of a benefits versus risk assessment. And it's still early on, and the data is still evolving, and we're still learning more. But we know with experience with other multi-dose vaccines is that the longer you extend the interval out between the doses, the better the immune response is. So usually if you look at, hepatitis B or HPV vaccines that require multiple doses, you never have to restart a vaccine series. And that's kind of the principle with the with COVID vaccines as well. So there's no maximum time, there's a minimal interval of 28 days.
Great, thank you. And Ajit, something that you alluded to was the protection that COVID infection provides itself. So post-infection, the antibody. So can you just refresh our memory as to what the vaccine requirements are for someone who has had the COVID infection?
Yeah, that's a really good question, Phil. So at the start, when vaccine supply was not as robust as it was, those individuals who were previously infected with COVID would defer their immunization from 3 months from infection to basically ride the wave of that antibody response from the wild type infection to allow others who didn't have that to get vaccinated. That changed very quickly now that there's more vaccine available. So even if individuals had COVID-19, they should still get 2 doses of the vaccine. There's none of this. They just need 1, or they don't need any. They get 2 doses of the vaccination, regardless of their COVID-19 infection status. And as going back to the trial data, individuals who had COVID were not excluded from the trial, and they still exhibited the same level of protection with no increase of adverse events as those who tested negative.
Great. Thank you for that. Angel, you spoke about long COVID, and I think this is something that our patients will really be asking about. Is there any hope about a therapy that would put long COVID into remission, or are we strictly looking at symptomatic treatments at this point?
Yeah, unfortunately, it's just a symptomatic treatment at this point. And unfortunately, because this long COVID syndrome is more of the complication of the infection, it's not an acute infectious process. It's just a complication of it afterwards. So it's really just symptomatic management. It's very, very similar to chronic fatigue syndrome that we see in patients who have other types of bacterial or viral infections, where they can develop, a chronic fatigue syndrome afterwards, along with a myriad of other symptoms that are akin to long COVID. So really, it's just symptomatic management for now. And that's why we need these multidisciplinary clinics with physiotherapists, occupational therapists, rheumatologists, neurologists, et cetera.
Great, thanks. And regarding myocarditis, because this is a subject that I think is going to come up more and more as the vaccines are approved in younger age groups. Do you think there will be an age breakdown in the, for example, 5 to 11 age category? Perhaps this is something that the submission to Health Canada will focus on, whether or not that occurred in the trials, because there will be parents who ask pharmacists, well, what specifically is the rate of myocarditis in my 6-year-old, let's say?
I mean, they will always try to break it down by age groups. Usually, it depends on the range, and sometimes it's not as granular as, like a 2 to 3 year gap, but usually they just do tend to break it down. The concern, of course, is that the myocarditis is extremely rare. So the cases may be so rare that it may not actually be captured in the clinical trials. Because like I say, with the adult vaccine trials, they didn't see myocarditis, pericarditis at all. And so in the pediatric trials, it may even be a much rarer phenomenon. Mm-hmm. And so that may not even be captured at all. And we may have to look at the real world data to guide more information. But again, from what we're seeing with the real world data in adults is that the risk of myocarditis, pericarditis is much higher after natural infection than from the vaccine itself. So it may be a very similar story in the pediatrics as well.
Great, thank you. Next question is for Ajit. there's a lot of discussion right now, both in professional circles and also in the media, around the whole topic of global vaccine equity. And I think that it's almost guaranteed that there are patients coming into pharmacies right now asking about a third dose, even though they may not really qualify under the current criteria. How do you suggest a pharmacist might approach this in discussing it with their patients?
Well, that's a really good question as well. So it definitely is an equity issue, and I think there's a really good quote, not by myself, but by someone else, who says, nobody's safe until everybody's safe. And with the large infection rates we're seeing in countries that don't have the ability to access a vaccination, it definitely brings an equity issue. The WHO has sounded off on it as well. It's saying, telling countries not to offer booster doses, but what's really disappointing is sort of the privilege we see in countries like Canada, where there are vaccines available, and people aren't taking them. And not only are they not taking them, some of them are being so vocal as to harass healthcare workers and protest certain things, when in reality, being able to decline a vaccine is a privilege in itself when we look at regions that don't have it. So again, it's just encouraging higher vaccine uptake with the doses we have. We don't have a lot of data on boosters. We do have data to show that those who are vaccinated do much better than those who are unvaccinated. And there is this sort of threshold of moving forward where, perhaps we can't eradicate COVID at this time, like we've seen with things like smallpox. That takes time. It's hard to vaccinate your way out of a pandemic. It's better to vaccinate to prevent it. So hopefully we'll get to that point, but it's using the doses we have and getting to that herd immunity that's acceptable. So reassuring patients that are double vaccinated that they've done the right thing to protect themselves and others, and reassuring them with the data that myself and Angel have shared today to show how much better they do against COVID and its complications.
Excellent. Great. Thanks. Angel, we had a question as well, and I think the NACI recommendation goes into this, but are there, aside from the broad class of individuals who are immunocompromised, are there specific guidelines in patients who are on biologic or conventional DMARDs? And I think there is, but maybe you could refresh our memory.
Yeah, so NACI just, because the levels of immunocompromise are so variable depending on the medications, but anybody who's on biologics, DMARDs, anti-CD20 medications, that's all classified as immunocompromised, as well as disease states too. So not just by medication, but by disease states. So those who have malignancies, for example, they're classified as immunocompromised, transplant populations. So it's very, very broad. And so that's why NACI kind of left it open like that. So pretty much anybody who's on any advanced level of immunosuppression by a disease state or by medication should get that third dose.
Great, excellent. This one is for Ajit. Are you seeing increased requests or more pharmacies offering rapid testing, and how do you see the role of this in terms of this stage of the pandemic?
Yeah, that's a good question. I think that a lot of this, I guess, hinges on the federal election to see what role testing will play versus vaccinations. But I think that for things like, being involved in travel medicine, I think that a lot of countries are requiring the double dose of a vaccine and a negative PCR test within 72 hours. So we are getting requests for that. But it's tough to say. I think that we'll have to see how the vaccine's going to be tracked and identified in people, and if that doesn't turn out to be something that works very robustly, we may go back to testing to move forward with sort of gatherings and travel. So it's a very kind of like at its tipping point at this time. So I'm sure there's, I think for travel right now, like for example, to the United States, still requiring a negative PCR test to New York, Vegas, or wherever. If that changes, then we can expect the demand to go down, because when you're going somewhere, more people are traveling domestically and across the border than they are going to places like Africa. So we'll have to really see. It's one of those things, and that's where travel medicine has been a moving target. with some of the each country having its own specific requirements.
Absolutely. Yeah, definitely a challenging environment, that's for sure. The next question is for Angel. You alluded to the fact of when an immunocompromised patient might be most suited to have a third dose. And so the question came out, which I think is an interesting one, is for someone who is using a biologic like Stelara, when would be the best time? Would it be, for example, at the end of their, once their dose has basically dissipated and they're due for the next one, or when do you think would be the best time?
Yeah, so I mean, it's a balanced issue, right? So on the one hand, you don't want to delay their biologic because you don't want their disease state to get out of control. But on the other hand, you don't want to delay the vaccine. And so NACI always recommends at the lowest point of their immunosuppression. So if they're on an infusion, then you generally tend to, if you can't hold their next level or their next dose, then to give it at the end of, just prior to their next dose, because that would be their lowest level of immunosuppression. But NACI says to never defer a vaccine in order to achieve that lowest state of immunosuppression.
Excellent, great, thanks. Ajit, I wonder if you could maybe delve into this next question a little more, and that is that I think there is, there's bound to be some complacency about influenza shots, which are probably going to start to be administered, next month or late next month. Can you suggest strategies that pharmacists might use to try and encourage their patients to get the flu shot in addition to any missed doses of their COVID vaccine?
Yeah, so I think that's a good point. I did allude to some of the potential complacency around last year being a low burden season. In reality, in fact, what I've seen in frontline practice is not necessarily that complacency around a low burden influenza season. It's about individuals who've been vaccinated against COVID and think that that's good enough going into the fall season. So that they kind of use the influenza vaccination as sort of a substitute for COVID not being available, because that's what a lot of the healthcare professionals were urging. But now that they've gotten the COVID vaccine, that's sort of the end all be all of their sort of vaccination endeavors. So the best strategy I've had is to kind of explain their different diseases, yet they still cause the same potential battery of symptoms and complications as well. So I think that's something that I think a lot of pharmacists should keep their eye out, especially in those individuals who've been vaccinated against COVID, got their flu shot last year, because we did see an uptake in it, and may not think that they need it, not because they kind of looked and saw, okay, I don't need it, but they just weren't aware, and simply just reminding them from a healthcare professional that they know and trust, reminding them, certainly I've seen in my experience, gets them back on the getting the influenza vaccine this season.
Perfect, thank you. And maybe the next question I'm going to ask both of you to weigh in on is, it's a question that's come up on a number of our COVID conversation webinars, and it doesn't seem to go away, and it continues to be addressed in the media. But the whole question of ivermectin, I know that, in some circles we tend to dismiss it, but the question does keep coming up. And is there any evidence at this point that there's positive treatment benefit? Or is there any merit whatsoever, or how should we address questions from our patients about this?
Yeah, so the whole ivermectin keeps getting cycled over and over again. So early on in the pandemic, it was brought up, and then recently, I think because of Joe Rogan, and he's been promoting it on his podcast or mentioned it. I haven't listened to it. It's just what I've heard, and so it's come up again. But there have been large-scale trials, actually properly conducted clinical trials using ivermectin, and there's no scientific data for it, unfortunately. I mean, I wish there was, but there just isn't.
Great, thank you.
Yeah, but in terms of the ivermectin issue, I mean, this is no stranger. I mean, we saw the same with hydroxychloroquine and azithromycin, and it's just really unfortunate that these, again, it's better to prevent a disease than to treat it with any, regardless of the efficacy. Again, ivermectin is reserved for, again, working in the travel medicine space for very specific infections, usually residents of endemic areas of diseases like strongyloides, where this medication is extremely effective. And unfortunately, we're seeing limited access based on potential run on supplies of ivermectin for, as Angel mentioned, there's no data on it. So we've got to be careful with some of the consequences of these unproven therapies, not just from the patient level, but for other people who actually need the drug. As we saw the same thing with hydroxychloroquine as well for rheumatoid arthritis, and same thing with ivermectin.
Excellent. Thank you for that, both of you, for that response. I'd just like to remind our listeners that CPHA released a comment on ivermectin last week, and would welcome you to go to our website to read the comment. It's really in line with what a lot of other organizations have said about ivermectin. Really, that there's no evidence to really support it, but there could be potential effects that are quite serious. So I would really encourage you to go there and to read it if you have a moment. Another question, I guess, about this whole topic of someone on immunosuppressed medication, and that is, if someone has received the COVID third dose, how long should they wait before actually starting an immunosuppressant medication?
Yeah, that's, again, it's a tricky one just because it's, the half-lives of medications are so variable, and also the level of immunosuppression of the medications are so variable. And so when you actually read the immunization guidelines for immunosuppressed people, according to NACI, it's really, in consultation on a case-by-case basis with the rheumatologist or the infectious disease specialist, because some of these half-lives can be months, and sometimes some of these drugs, the half-lives are, days to weeks. And so again, the principle is just, a vaccine is better than nothing. And so if you can hold the immunosuppressive medication to optimize their immune response and not sacrifice or, a flare of their disease state, then great. But if you can't, and you can't risk that patient having a flare of their disease by holding the medication, then it's best just to give them the vaccine. And then if at a point later on down the road, if they're in remission or if they can come off their immunosuppressive medication, you can always revaccinate them at that point. But just never delay the dose of vaccine or delay their medication just to give them the vaccine.
Great, thank you for that. I think this will perhaps be the last question, and I'll direct it to Dr. Chu, and that is, we've been reading reports, quite tragic reports of newborns that have not survived COVID infection. And I guess the question is there a difference in disease severity in newborns compared to other children under 12 years of age with respect to having, I guess, immature immune systems and being unable to actually combat COVID?
Yeah, so children again tend to be very resilient for some reason against COVID, unlike with other respiratory infections that we see. I mean, there always are going to be those few reports of a newborn, these tragic events that happen that are exceedingly rare, but it just gets media attention because of how much it hits home and how tragic they are. So I mean, we see newborns and unfortunately babies die from things like influenza every year on an annual basis. And it's just, again, a reminder of the importance of these vaccines and the necessity of community level protection in order to protect our vulnerable populations, such as newborns and those who can't be vaccinated because of their immune systems or because they can't be optimally protected with vaccines themselves. So, with regards to newborns, it's exceedingly rare. And I don't know that there's enough information out in the literature to suggest that they respond differently to COVID infections compared to older children. But it's just one of these things where in order to best protect everybody, we should all ensure adequate levels and high levels of immunization.
Great. Excellent. Thank you for that. Thank you very much again for sharing your expertise with us and really being put on the spot in terms of some great questions that came up today. So that brings our session to a close. On behalf of CPHA, I'd like to thank Pfizer Canada, our two presenters today, and all of you who joined us and took time out of your schedule to join us for this webinar. Just before we sign off, just a reminder that there will be a recording of the session plus the slide deck in our webinar library within 2 weeks. So please encourage you to go there if you'd like to see it again, or if you'd like to encourage your friends to access it. We'd also be really grateful if you would complete the evaluation survey that's going to open up on your screen imminently or within a few minutes. we really rely on your feedback to come up with excellent sessions for future webinars focused on current areas within pharmacy practice. So please let us know those topics that you're most interested in our post-webinar evaluation survey. And on behalf of myself, a CPHA, and our speakers today, we'd like to thank you for joining us, and we'll see you again soon. Thank you.